So for the first talk, I would like to invite Dr. Sandeep Kumar, who would be talking on the science and clinical potential of amniotic membrane graft in ophthalmology.
A very good morning. I'll be discussing on the science and the clinical potentials of amnion membrane graft in ophthalmology. The amniotic membrane, a biologically active extracellular matrix, has emerged as a pivotal tool in ophthalmic regenerative medicine. Its anti-inflammatory, anti-fibrotic, and pro-regenerative properties provide a unique therapeutic advantage in both anterior and posterior segment pathologies. This presentation dwells into the anatomy and cellular mechanisms related to the clinical application.
Slides are not moving, I think. Now they move.
So the fetal development is achieved by a complex system consisting of umbilical cord, amniotic fluid, and placenta. The fetal membrane basically consists of an outer chorion layer and an inner amniotic membrane, which is a thin membrane on the inner side of the placenta. It completely surrounds the fetus and delimits the amniotic cavity, which is filled by amniotic fluid. It's a translucent biological structure that has no nerves, muscles, or lymph vessels. Its thickness varies from 0.02 mm to 0.5 mm and consists in the three main histological layers: the epithelial layer, the basement membrane, and the avascular mesenchymal layer. The epithelial layer has cuboidal cells which are firmly attached to the basement membrane, which is a condensed acellular composed of collagen 1, 2, and 5. Amniotic membranes, epithelial cells, have microvilli at their apical surfaces and probably have an active secretory function. Going back to the history, in 1910, Davis used amniotic membrane for skin for the first time because of its tensile strength and its inert nature. After that, Stern and Sabella in 1913 used amniotic membrane for the management of skin, burns, and superficial wound, basically on its anti-inflammatory properties. After that, it gained attractive treatment for, became an attractive choice for the treatments with the genitourinary tract, oral cavities, skin, stomach, larynx, and head and neck cancers. It found its way to in ophthalmology in 1940s when D. Roth first used for conjunctival reconstruction. After that, it gained popularity when Kim and Singh used it for multiple pathologies in 1995. Over the years, advancement in preservation techniques have expanded their application in ocular surface and retinal diseases. Now we'll be discussing about the amniotic properties and applications. The main objective of MTR ocular surface reconstruction, promotion of epithelialization, providing symptomatic relief, and reducing inflammation. Now, the scientific basis for the use of amniotic membrane graft for transplant are these anti-inflammatory, anti-fibrotic, pro-regenerative pluripotency, immunomodulatory, and biocompatibility. We will be discussing them one by one. So the amniotic membrane, the derived cells possess pluripotent properties, making them an attractive source for transplantation. These cells can differentiate into all three germ layers, the ectoderm, mesoderm, and ectoderm, and they also have stem cell markers. They have been seen to differentiate into hepatocytes, cardiomyocytes. They have been helpful in cartilage repair and insulin production. The anti-inflammatory characteristics are because of the production of anti-inflammatory factors like IL-1 and IL-2 receptor antagonist, IL-10 and endostatins. In addition, it also produces alpha-1 antitrypsin, which is a protease inhibitors and has an anti-inflammatory effect. This is further promoted by increased apoptosis of neutrophils following the application of human amniotic membrane to therapid corneas following PTK throughout the expression of pro-apoptotic ligands CD95 on the surface of mesenchymal cells. Amniotic membrane is a promoter of epithelialization. The composition of amniotic membrane not only provides a physical barrier, but promotes the migration of epithelial cells and their differentiation that leads to strengthened adhesion of the basal epithelial cells. It also produces platelet-derived growth factors, human growth factors, keratocyte growth factors that promote survival, proliferation, and migration of epithelial cells. The anti-angiogenic properties maintains the avascular surface of the cornea, preventing the new blood vessel formation. The production of anti-angiogenic compounds such as thrombospondin 1, endostatin, and tissue inhibitors metalloproteinase has been demonstrated in vitro in human amniotic membranes. Amniotic membrane suppresses TGF-beta receptor and the factor signaling in fibroblasts, reducing fibroblast activity and the differentiation of fibroblasts into myofibroblasts. This process results in the reduced scar formation with less scarring observed in corneas treated with AMT following alkali-induced damages. The membrane also produces intrinsic antimicrobial properties, improving outcomes in bacterial keratitis compared to the antibiotics alone. Cells of AM produces beta defensins, antimicrobial peptides expressed in mucosal surfaces. In addition, it also demonstrates antiviral properties attributed to its expression of cystatin A, suppressing the viral infection that has been helpful in the herpes simplex keratitis. It has an immunomodulatory effect demonstrating limited HLA-1A and 1B antigen. This leads to minimal immunological rejection, eliminating the need for immunosuppression post-AMT. Now, the preparation and technique parts. The placenta is procured at cesarean section, preferably an elective one. Meconium-stained placenta or with high crust are avoided. This is collected from OT in sterile drape and brought to laminate flow bench. The peeling of onion is done after finding out a plane and is then gently washed using plenty of sterile water. It's finally stored in 50 ml sterile container containing about 1 gram Genta, 1 strepto, and 10 ml of fluconazole. It's capped and mixed by inversion several times. It's stored in refrigerator till ready for cleaning and after getting the viral markers clear. The cleaning is done in sterile tray using soft brush, and the care is taken to clean all the blood and gelatinous material sticking to the matrix side. The media preparation consists of water, 1 gram gentamicin, streptomycin, and 25 ml fluconazole, and the pH is adjusted. The cryoprotectant media is prepared using this medium and 50% glycerol. Filtration is done via 0.2 micron syringe filter, and finally 1 vial of amphotericin B is added to the cryoprotect aseptically. The sterile membrane filters are used to stick the amniotic membrane matrix side down and then cut to size 3 centimeter by 3 centimeter and roll filled to 2 ml sterile vials. These vials can be stored at below -20 degrees for at least 1 year before use. Now the storage part, which is the mainstay, is cryopreservation. This process involves placing the amniotic membrane in storage solution in a 1-to-1 ratio of 86% glycerol in Dulbeck modified Eagles medium and storing it in -80 degrees Celsius. Stable storage at this temperature allows the membrane to be used for up to 1 to 2 years. However, the preservation concerns about potential damage to the amniotic membrane integrity due to its crystallization within the tissue. This can reduce the anti-inflammatory effect and the antiogenic intermediates. The second one is lyophilization, which is a freeze drying for amniotic membrane. It involves rapidly freezing it to -80 degrees Celsius, followed by the use of high vacuum to dry the tissue, and this eliminates the need for cold storage and logistical challenges associated with cryopreservation. The third one is the dehydration, which involves placing the membrane in a vacuum and dried at -3.5 to 6 degrees Celsius after removing the spongy layer and pre-treating it with raffinose and incubating with the broad-spectrum antimicrobials. It has been seen that the application of lipoprotective saccharides such as trehalose or raffinose has been demonstrated to preserve the biochemical stability of multiple growth factors and enzymes crucial to the antifibrotic and anti-inflammatory properties of amniotic membrane. Both fresh and preserved amniotic membrane have been found to function equally well when transplanted onto ocular surface. However, there are certain concerns when using a fresh AM. With fresh AM, the short time interval from the tissue procurement to transplantation prevents repeat testing of the donor. Patients have been brought to the hospital at short notice, unlike with preserved AM, which allows more flexibility in the scheduling surgery. A distinct disadvantage being the wastage of the unused tissue. Let's look at some of the commercially available amniotic membrane preparations. New Vision makes Omnigen and OmniLens. Omnigen is available in multiple forms with epithelial side up, clearly marked for the proper orientation during the application. And it comes in various diameter according to size and in various shapes, rectangular and square sheets. The other being OmniLens variety, which is, it combines preserved amniotic membrane with soft contact lenses, allowing for sutureless application in clinical settings without requiring a surgical theater. The BioTissue uses cryopreserved amniotic membranes, the main being the AmnioGraft and AmnioGuard, both produced in various rectangular sheets. The AmnioGuard is a thicker one and is specialized for additional tissue support. OcuFix 2 is a gamma-irradiated and processed aminoglycoside antibiotic membrane. It can be stored for an impressive 5-year shelf life, and it's available as a 16 mm disc sheet or various square or rectangular sheets. Finally, the Visio Emitrix, which is a lyophilized amniotic membrane, and it can be stored at room temperature for up to 5 years. Recently reported as an effective treatment for persistent epithelial defects when applied in sutureless fashion with a bandage, simplifying the application process. Now, all these deeper insight in the properties of amniotic membrane has led to has revolutionized and expanded its role in the ophthalmology. It has been is found its way through ocular surface disorders in corneal ulcer, persistent epithelial defects, pterygium surgery, Steven-Johnson syndrome, surface reconstructions, glaucoma filtration surgery, and has been started to use as a scaffold in optic disc maculopathy, which will be discussed by the subsequent speakers. So amniotic membrane grafting represents a significant advancement in ophthalmic care due to its regenerative, anti-inflammatory, and anti-scarring properties. Its established role in ocular surface disease and expanding application in retinal surgery highlights its clinical potential. Continued research and innovation will further refine its use, offering hope for improved patient outcomes in challenging ophthalmic conditions. Thank you.
Thank you, Dr. Sandeep. I would just want to ask you that, so basically, I think that there's a very extensive introduction to amniotic membrane, and so just for the general use, I think, anyways, as ophthalmologist, I don't think we all have access to a gynae lab. So what is the way of procuring? I mean, do we very easily get it for use, or just for the general practitioner, like how
So-
easy is to procure the membrane and use it?
We generally use the cryopreserved through the wet AMG bank. We have it is available very easily on contacts only.
Right.
Yeah.
Okay. And so, anybody from the audience, I mean, any experience with a dehydrated graft? If anybody used that, or any questions? So, from the cornea side, I think.
So I don't think we found it very useful to use dry amniotic membrane. It is used, I think, by the glaucoma specialists. Sometimes they have been using that, the dehydrated amniotic membrane. For corneal indications like chemical burns, it doesn't seem to work very well. Although now this, in terms of you can procure cryopreserved, there are some companies which are selling it as well. So that is becoming more readily available, the wet membrane through that. So,
Right.
so it can
Thank
be